We're going to be talking today about an issue that, although it doesn't come up very frequently, when it does, it's a considerable problem. And that is the difficulty when a woman has some type of infection and during pregnancy, and the question is, what is the impact on the newborn and how do we manage the newborn? So that's going to be the focus of our conversation today. Now, the reason this is important is because sexually transmitted diseases occur at a significantly higher rate in chemically dependent women than in the general population. Overall, when we consider all the different sexually transmitted diseases, the rate is a little above 1% of the general population. However, in women with histories of chemical dependence, and I do include alcohol when I talk about chemical dependence in this sense, the rate is 8%. Now, this is the long list of infections that we should be particularly concerned about. All of these infections are transmitted through sexual contact, and as we talk about each one of them individually, some of them also can be transmitted through intravenous drug use or sharing needles. Now, the reason I specifically mentioned alcohol is because I have many patients who come to me and say they're abusing alcohol. Why should they be tested, for example, for HIV infection? The reason is that a woman who is using alcohol extensively is going to be much more likely to have unprotected sex. And whenever she puts herself in that position of having unprotected sex, then of course she is increasing her risk for acquiring a sexually transmitted disease. Now, the first infection we're going to talk about is chlamydia. Chlamydia is the most common sexually transmitted disease in the United States. It infects both men and women. Now, of course, the group we're most concerned about today is women. Chlamydial infections in women can produce pelvic inflammatory disease, so in fact can impede a woman's ability to get pregnant. Because of the inflammatory process, you can get inflammation in the tubes so that the pregnancy can place itself in the tube rather than the conceptus making it all the way to the uterus. And so we get an increased rate of ectopic pregnancy. When a woman has chlamydia during pregnancy, the baby's exposure is usually through the birth canal. And so all women who are pregnant should be screened for chlamydial infections. If it's treated during pregnancy, the likelihood that the newborn will be infected is almost next to nothing. Unfortunately, chlamydia can sometimes just be completely asymptomatic. And so a newborn could be infected through the birth canal when the woman doesn't even realize she herself has a chlamydial infection. If a woman is infected with chlamydia, there's about a 40% chance the newborn infant will be infected. The most common presentation is a conjunctivitis, inflammation of the eyes with quite a bit of discharge, and pneumonia. Now, in most circumstances, this will show up relatively early, but it won't necessarily be in that immediate period after delivery, so that many infants go home only to present to their pediatricians on an outpatient basis in the following weeks. Gonorrhea, of course, everyone is quite familiar with the issue of gonorrhea. In women, again, gonorrhea can produce pelvic inflammatory disease, ectopic pregnancies, and infertility. And gonorrhea also is transmitted through the birth canal. Gonorrhea can be asymptomatic, but often the women will have vaginal discharge, and it's more obvious that the woman is infected. If a woman does have gonorrhea, she's going to require a cesarean section. The baby should not be delivered vaginally. The complications for the newborn can be quite severe, affecting the eyes, resulting in, again, a conjunctivitis, a significant inflammation of the eyes, and blindness. The babies can present with joint inflammation, and the blood can become infected, so the baby can develop a sepsis. And this, of course, is a life-threatening emergency. Now, thankfully, gonorrhea is fairly well treated with penicillin. And so all infants who might be at risk for gonorrhea infection should be watched very closely and treated immediately if any signs or symptoms began to appear. Relatively new on the horizon is Group B strep. Now, Group B strep is not transmitted sexually, but it's an important infection to talk about. Because many women with drug use do not get prenatal care, this is something that can sneak up on us. The mothers are almost always asymptomatic. And the only way to pick up if a woman is infected with Group B strep is by doing specific testing. So in general, all women who are pregnant and receiving prenatal care do get Group B strep testing. And if the woman is positive, she'll be treated prophylactically with penicillin, and this prevents any complications for the newborn. So it's really a very simple approach to prevention. All women who are receiving prenatal care get testing for Group B strep. If positive, they get treated with penicillin. Unfortunately, many women, as I said, who are using drugs don't get prenatal care. And so we're not going to have access to them until they present for labor and delivery. You still should do the blood tests to see if she is infected, because the symptoms in the newborn may not present right away. And if you find out the mother is infected, then you can go ahead and treat the baby before he becomes infected. There are two phases or times when babies can show symptoms of infection. The first is early onset, and within the first 6 hours or so after birth, the baby can become symptomatic, and all the way up to about the first week of life. Late onset, and these are the babies we most worry about because they go home, they're home with their mothers, and this disease process can progress very rapidly, so that the baby can become very sick very fast. And that's the late onset, and it's after the baby's been home for about a week or so. Again, that's why it's so important to test all women during pregnancy, and if they have no prenatal care, then to test them in the labor and delivery suite. The initial presentation for most babies who have Group B infections will be with a pneumonitis. You'll see changes in respiratory rate, difficulty breathing. It will develop into a full-blown pneumonia. Even more seriously, the babies can be septic, that is, can have the Group B strep infection in their blood, and they can develop a meningitis, which is an infection in the spinal fluid. All of these, the pneumonia, the sepsis, the meningitis, are life-threatening and need to be addressed immediately. Again, the best approach is prevention, because if we realize a woman is pregnant with Group B strep, she can be treated and the baby will be fully protected. Now, if a woman is infected with Group B strep and the baby is born and does not get infected, we're still not out of the woods, because babies can acquire Group B strep from an infected individual after they're born. And so that's another reason for testing all women, no matter when we have access to them during the prenatal period or during labor and delivery. The next area is herpes. Now, herpes, again, is very difficult to address because so many women with herpes are completely asymptomatic and may, in fact, not even know they're infected. Herpes is transmitted by sexual contact. It can be either through intercourse or through oral contact, so that you can acquire herpes either way. If a person is symptomatic, they will have small, painful lesions all over the genitals. And this is when it's most dangerous for a baby, because the baby can be exposed to those lesions as he passes through the birth canal, and that's how the baby gets infected. It's a serious infection and can cause encephalitis in the newborn. So all women should be screened for herpes during pregnancy. Now, the real issue comes up when we begin to talk, should all women who have a history of herpes infection, should all of these women be delivered by cesarean section? Because we know babies acquire the herpes when they pass through the birth canal, perhaps we can avoid their exposure by delivering them by cesarean section. And this is where it gets a little more complicated. If a woman was infected with the herpes before she got pregnant, or at least before the 3rd trimester, and she has no symptoms, and is not having those tingling feelings that people often have in their genitals before they break out, and there are no symptoms and no feelings of an impending outbreak, then a woman can deliver vaginally. In this case, when a woman is known to have had herpes before pregnancy or before at least 3rd trimester, she has no active lesions and no symptoms of impending lesions, then there's less than a 1% chance that the baby will actually contract the disease. Now, the reason we can say that is that soon after a woman is infected, she will develop antibodies to the herpes. And those antibodies can cross over the placenta to the baby. So in 6 to 12 weeks after exposure from the mother, the baby will have some immunity to these antibodies, which will protect him partially if the woman is unknowingly shedding the virus. So that's why we can say if the woman had the infection before 3rd trimester, she should have developed the antibodies, pass them to the baby, and so he does have some protection. On the other hand, no matter how long she's had the herpes infection, if she's having an outbreak or symptoms of an impending outbreak, then when she goes into labor, then she has to have a cesarean section immediately. The indications for the cesarean section are if there are any visible lesions on the cervix, the vagina, or the external genitals, or any symptoms like tingling, burning, or pain that sometimes signal an imminent outbreak. In either of those sections, it is important that the woman have an immediate C-section. One approach that's being used currently is, and this is recommended by the American College of Obstetricians and Gynecologists, that if there is a pregnant woman who has a history of recurrent genital herpes, then she should start oral antiviral medications from 36 weeks gestation until the time of delivery. And that should prove protective for both the mother and the babies. Now, there's one other exception to these rules I've given you. If you get genital herpes late in pregnancy, and blood tests confirm that you've never had it before, but you've acquired it now into 3rd trimester, and even if you don't have any signs or symptoms, you should have a C-section. The problem is that this is a new infection, and the baby just hasn't had the time to develop antibodies or to receive your antibodies that the pregnant woman has developed. Early in infection, the virus tends to be present in relatively high concentrations, and it's more likely that the woman will be shedding virus during labor. If the woman is shedding, the risk of transmission to the baby is very high, up to 50%. So again, we emphasize that if the woman has for a long time known that she was infected with herpes, then starting at 36 weeks, she should get treatment with antiviral medications, and she most likely will be able to deliver vaginally. However, if that's not the case and it's a relatively new infection, she needs to be delivered by C-section. The next area is syphilis. Now, syphilis, again, is transmitted through the birth canal, and I think most people are familiar with the difficulties associated with syphilis. In the newborn, it can produce neurologic and central nervous system problems. It can cause blindness, and ultimately can cause death also. The good news is syphilis is totally treatable with penicillin. The problem, if a woman has a positive test for syphilis, testing in the newborn is complicated because the woman's antibodies that she's produced against syphilis can cross to the fetus. So when you test the baby can be positive also. Most physicians will end up treating a baby for syphilis even if the baby is negative. Now that may be a little bit overkill, but any woman who has syphilis the baby does need to be tested. So in general, treatment decisions need to be made based on the identification of syphilis in the mother. Does she have syphilis? Number two, was she treated? Now, if the mother was treated and got a full course of penicillin for syphilis during pregnancy, then she should be okay and the baby should be okay. If there is clinical evidence of syphilis in the infant, for instance, you do a syphilis test on the baby and it is positive, then the baby probably needs to be treated. And especially if you use the same test to measure the level of syphilis antibodies in the mother, and then you test the baby, and if the baby's syphilis antibody test, his titers are higher than in the mother's, you surely need to treat. The other thing that you might want to do is x-rays to see if there are any changes in the long bones of the skeleton of the fetus, because that is another true sign of syphilis infection in the baby. So, all infants whose mothers have positive syphilis tests should be tested themselves. And let me just mention here, you cannot use umbilical cord blood because the cord blood can be contaminated with the mother's blood and could give you a false positive. So you just do an RPR or a VDRL. Those are the common tests available, and that's what can guide you as to whether the baby should need treatment or not. If a baby's RPR or VDRL is positive, then you do need to do further testing on the babies to see about active infection, including a spinal tap to see if the central nervous system fluid is infected. And you need to do a blood count, CBC, with platelet testing. And then, as clinically indicated, you may need to do long bone radiographs, a chest x-ray, liver function tests, and may need to look at cranial ultrasounds. All these babies that you suspect are infected with syphilis also should be seen by an ophthalmologist to check the status of the eyes. Now, if a baby is positive, or it does appear that the baby does have syphilis, then he can be treated in one of two ways. You can give aqueous crystalline penicillin G, about 50,000 units per kilogram per dose, IV, every 12 hours for 7 days, follow up by the same dosage regimen every 8 hours to make a total of 10 days. So that's dosing every 12 hours with penicillin G IV, every 12 hours for 7 days, and then every 8 hours for the remaining 3 days to make a total of 10 days of treatment. Now that is rather onerous, and if you miss more than 1 day of therapy for any reason, then you have to start all over. That's why many physicians prefer to go with a single dose, and you give the baby procaine penicillin in a single IM dose each day for 10 days. So rather than having to give an IV dose, which would probably require continued hospitalization, you give just a single IM dose once a day for 10 days. Again, if you miss, now that can be done on an outpatient, but if you miss more than 1 day of therapy, you have to start all over. Now, some folks ask about ampicillin rather than penicillin. Penicillin is the preferred agent. And of course, the baby will need close serologic follow-up to assess the adequacy of the therapy over time. The next infection we're going to talk about is hepatitis B. Now, most physicians will screen pregnant women for hepatitis B. And in this day and age, most adults have now received hepatitis B vaccines. Hepatitis B, again, is transmitted through the birth canal and can produce liver failure, cirrhosis, and cancer of the liver. It was becoming more and more of a problem, but then in the last several years, we've had available to us a vaccine for hepatitis B. So it is the strong recommendation now, best practice, that all children within 12 hours of birth receive their first dose of hepatitis B vaccine. And if not within 12 hours, certainly prior to discharge from the hospital. The second dose then is at 1 to 3 months of age, and a third dose is at 6 to 18 months of age. The usual pattern is a dose of hepatitis B vaccine at birth, a second dose at 3 months, and a third dose at 6 months. There are occasions when a child may need a fourth dose, but that's highly unusual and is a clinical decision that has to be individualized. There are no documented long-term implications or complications from the hepatitis B vaccine. It's been used universally for several years now. The problem that we run into is that some insurance companies still do not cover hepatitis B vaccines, nor in some states does Medicaid, so that some hospitals are not giving the hepatitis B vaccine prior to discharge, but are telling families to go to the Board of Health or their own physician to get the hepatitis B vaccine. If you are working with a woman who has a history of chemical dependence, you do need to make sure the baby gets the hepatitis B vaccine prior to discharge. And in this special high-risk population, I would say you need to try to get that vaccine to the baby before 12 hours of age. Now, we're going to talk now about HIV and AIDS. And this is a very difficult subject, especially to try to communicate through a webinar. And I'm going to try and make this as clear as possible. This diagram, you can see the placenta there, separating the maternal and the fetal side of the placenta. If a woman has HIV virus, so she's infected with the HIV virus, whether she's symptomatic or not, whether she has AIDS or not, if she is infected with the human immunodeficiency virus, then she will produce HIV antibodies. The HIV antibody is an IgG antibody, which means it crosses the placenta very readily. So on the baby, so when you test a baby, if the mother has an HIV infection, 100% of babies will be HIV positive because it's the mother's antibody that has crossed the placenta. That makes it difficult for us to figure out if, in fact, the baby is truly infected. By running an HIV antibody test on the baby, he's going to be positive. The question is that the mother's antibody, or has the HIV virus actually crossed the placenta so that there is maternal virus infecting the fetus, and so the fetus has now developed his own antibody? So with the HIV test, when we run an HIV test in a baby whose mother's infected and he's positive, we don't know if the baby is truly infected and that's his own antibody, or if it's the mother's antibody that we're measuring. Now, up until relatively recently, we didn't know whether the baby was truly infected or not for a good 15 to 18 months. And so we had to tell parents, and this especially came up with adoptive parents when they were considering adoption of a baby, we had to tell them that we wouldn't really know if the baby truly was infected with HIV and would get AIDS, or if this was just passive exposure of the antibody from the mother. For the last few years now, we have been able to offer families PCR testing. Now, PCR stands for polymerase chain reaction. And what that does is that measures RNA or DNA of the HIV virus. So now we can tell if it's the mother's or the baby's HIV that we're measuring. So it tells us that if there's true virus that has crossed the placenta, and we don't have to rely just on the antibody. The first step is always doing HIV testing. If a mother is infected, at birth the baby will be HIV positive. You can track the baby and wait for the HIV antibody to clear if it's the mother's, but again, that takes 15 to 18 months. So the usual pattern is if a woman is HIV positive, you move immediately to the PCR. The PCR on the baby. Now, if the PCR is positive in the baby, then that means that for all intents and purposes, he is infected. If the initial if the initial PCR is negative, you're going to continue to repeat it, probably by 6 months. Repeat it at 6 months, and if it continues, if it's still negative at if it's still negative at 6 months, you're pretty much out of the woods. Now, some parents and some physicians like to repeat this again at 12 to 15 months, the HIV test, to make sure the HIV antibody has cleared and repeat the PCR. That's clearly just an individual decision. But your responsibility in working with these families is to at least get the PCR relatively early on. Now, I hope that has been helpful. We haven't had any questions come in, so either you're completely lost or it's just clear as day. And of course, I hope it's the latter. Now, that was HIV and AIDS. The same principles apply to hepatitis C. Now, unfortunately, hepatitis C is not even considered a lot of times by clinicians who are working with the chemically dependent population. I can't tell you the number of stories I've had, the number of examples when a family is considering, for example, adopting a baby, and their adoption agency has done, made sure the baby got hepatitis B vaccine. They made sure the syphilis testing was negative in the mother. They even made sure that the mother and or the baby were HIV negative. And when we've seen the baby often after the parents have proceeded with adoption, and we do the hepatitis C test, it comes back positive. It by far is one of the most frequently missed diagnoses in the early newborn period because the babies are completely asymptomatic, and it is not general policy to test all pregnant women for hepatitis C. And so if you don't know if the mother is infected, you're certainly not going to know if the baby's infected. Now, our recommendation is all women with a history of chemical dependence should be tested for hepatitis C during pregnancy. Now, the transmission of hepatitis C, again, is through the birth canal, and it's about a 5% transmission rate, which is relatively low, but still significant. The transmission rate of hepatitis C from mother to baby is significantly higher if the mother, in addition to having hepatitis C, also is infected with HIV. Then the transmission rate of hepatitis C is much higher. The implications these days in the United States, hepatitis C is the most common cause of a need for a liver transplant. And having hepatitis C puts you at significantly higher risk for chronic liver disease, cirrhosis of the liver, and ultimately liver failure. So it is a significant health risk, and again, very important that we assess pregnant women and their newborns. Now, I'm going to go back to the same slide I showed you before for the HIV, and we can use this same information to help us understand hepatitis C. On the maternal side of the system, if the mother has hepatitis C, she will develop hepatitis C antibody. That antibody will cross the placenta to the fetus. So any woman who's hepatitis C positive will have a baby who is hepatitis C positive. But again, 95% of those babies who are hepatitis C positive will not be actually infected. To find out who's actually infected, we do a PCR for hepatitis C, measuring the RNA, DNA content in the maternal virus. If it's positive, that means that the baby is at risk. Now, this is the antibody. If the hepatitis C antibody is negative, then it's unlikely that it's a false negative. Now that situation occurs when you don't know hepatitis C status of the mother. This is often in infants who are in foster or adoptive care. You have no information about the mother. You do HIV hepatitis C screening, and because of the lack of any history, if the hepatitis C test is negative, then you're okay. You can repeat the hepatitis C antibody test at about 2 months just to make sure, especially if the first test was done when the baby was less than 6 weeks of age. But at 2 months, certainly if you have a hepatitis C antibody that's negative, then you're pretty well clear. However, if the antibody is positive, if the hepatitis C antibody is positive, you must do a PCR on the baby. The difficulty with a PCR is that it has a relatively high rate of giving us a false negative. So when a baby is about 6 weeks of age, for hepatitis C, the PCR has about a 20% chance of being a false negative. Now, the accuracy of a PCR increases over time, so that by 6 months of age, the chances for a false negative fall to about 10%. Now, many experts recommend a PCR not even being done until 6 months of age, because by 6 months of age, you're in pretty good shape that if it's negative, it's not a false negative. The reality is it's extremely difficult for most families, especially foster and adoptive families, to wait 6 months before you do the test. And so we will use statistics to help the families at least understand what's going on. We will do an initial PCR for hepatitis C at about, as soon as the baby is born or within the first 6 weeks. We'll repeat it around 2 months, and then we'll repeat it again at 6 months. This at least gives the family the statistical likelihood, if all of these are negative, that they know that their baby statistically probably is not infected. I hope this information has been helpful.